Okay, it looks like there's a great amount of you. More people are going to trickle in as it starts, but we are going to get going right now. So, hi everyone, I'm Sabina Kukuridziak. I'm the Knowledge Translation Specialist from CRISM National. Thank you all for being here today. Really wanted to start it off with a land acknowledgement, and please feel free in the chat to throw in where you're coming from, as I know we're all coming from across Canada. That would be really lovely. So while we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the land which we each call home. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people who call this land home. Please take a moment of reflection to acknowledge the past and continue to move forward in a spirit of truth, reconciliation, and collaboration to ensure a bright future for all. Okay, so I just have a couple little housekeeping points before we really kick off the presentation. The first one being that, like I mentioned, this presentation is being recorded. Everyone registered and everyone here today is going to receive it post webinar. We're also going to have it on a bunch of our platforms. So you absolutely will have access to it, and we encourage you to share it as you see fit as well. We are so excited to have all of you guys here. We know a lot of you have a lot of questions, which we highly encourage. I will let you know throughout the presentation, you will be unable to ask a question to our panelists, but please put any of those questions in the chat box. We will be monitoring them, and we will have a designated Q&A period at the very end of the presentation. And if during that time you have something you want to say out loud as a question, please make sure you raise your hand so that one of our co-hosts can unmute you. And with that, we will also have some information at the end regarding some resources and also some contact information if there's anything post-webinar that you want to reach out to, ask questions. We really encourage that as well. So with that, I'll get started. I will introduce our co-presenters, co-authors of the CRISM Guidelines, Dr. Evan Wood and Dr. Kim Corace. Thank you so much, and I will turn it over to them.
Thanks so much, Sabina. So yeah, my name's Evan Wood. I'm on unceded Coast Salish territory today. And yeah, full of gratitude for everybody for joining what I think is a really, relevant to so many people's practices and the clinical work that they do. So just jumping in with the first slide then. Um, in terms of the impact of this, Sabina, my slide's a little bit offset. Is that just me? That's better, actually. Sorry, I think it was just my computer. Yeah, in terms of the burden, the public health burden, I think we're all familiar, but the statistics are actually, pretty concerning. The Canadian data is sometimes lacking, but a paper that I've seen cited repeatedly in recent years is a JAMA Network Open paper that showed for individuals in the US between age 20 and 49, 1 in 5 deaths were attributable to alcohol. So not all of those would be alcohol use disorder, and that's relevant to the conversation today. But in terms of the public health burden, it's obviously very considerable, which is why we're all here today. And then the flip side of that, when we talk about the burden, the public health burden, screening and practice rates remain very low. And so there's Canadian data, there's US data that show that less than 5% of practices, and I am sympathetic that we're probably a select group that's joined here, but when you look at primary care sort of across the board, once you get to sort of 95%, because it's only 5% are screening, so 95% are not, I think we can sort of do a little bit of rounding and just assume that, in terms of at least standardized approaches to screening, almost do not happen universally. And I think with humility, we need to acknowledge that that's probably a problem with the historical screening recommendations. And I've been involved with some of those historical recommendations. So that's why I say with humility, these screening tools that have been used historically tend to be very time consuming. They're often developed for research contexts and they're not really relevant to sort of busy primary care contexts. And we'll talk a little bit today about the Alcohol Use Disorders Identification Test, which is a WHO developed screening test, or also known as the audit. But it's 10 questions, which is just totally impractical, I think, for a busy primary care context where also you have to do some math at the end of those 10 questions to identify where people would be in terms of their risk And then beyond that, if you did feel you had time in your clinic to do that, maybe a specialty environment or another environment, the reality is that the psychometric performance for the clinical epidemiologists that have gathered, the sensitivity and specificity is very poor. So, with the alcohol use disorders identification test, even for individuals who score at 8 or above, that context, about a third of individuals with an alcohol use disorder would be negative on the audit. And most importantly, it's unaligned with the latest guidance on safe levels of alcohol use, of which there's been some fairly dramatic changes, which I think all of you are familiar with. So if we go to the next slide, I think, yeah, unless you sort of were buried under a rock somewhere, because I think the CCSA has done a very good job of knowledge translation with this. There's been a real pendulum swing where it used to be for women, 10 or less drinks per week, you would still fall into the lower risk category, or for men, 15 or less drinks per week, you would still be defined in the lower risk category. Whereas with the publication of Canada's guidance on alcohol and health, or the CGAH, two drinks or less is the number of drinks above which harms begin to emerge. So that's been a big change. Next slide, please. So what's new in the guidance? The paper is there for you to see. The full paper is available, and it's not behind a paywall at the Canadian Medical Association Journal. But the idea is to move away from sort of time-consuming and frankly ineffective approaches. The old approach, again with humility, the 2023 guideline, which I was part of, recommended a sequential approach with a brief screening tool, and then if that was positive, a shorter screening tool, and then if that was positive, move on to a diagnosis. Again, I don't think that's going to change the sort of very low rate of screening historically. And obviously there's problems with that approach anyway. So the new approach is really moving towards more of a conversational nature to screening, incorporating the Canada's guidance in alcohol and health thresholds, identifying individuals who may have problems with their alcohol use, but providing specific feedback as it relates to that individual's unique problems, and then only seeking a diagnosis when it's appropriate to do so. So there's five recommendations, and we'll come around on these a couple of times. But just at the very top is that all adults and youth should be screened above or below Canada's guidance. Sorry, that background noise is in my environment, so I can't do anything about that. But bear with me. The routine part is the part that people are probably scratching their heads about. Okay, well, routine, what do you mean by routine? And the problem with developing these types of guidelines is that you really want something to hang your hat on in terms of, well, it's annual or it's every 6 months, and there isn't great evidence for how routinely screening should be done. So there's a couple of points here, and I think Kim will reinforce one of these points is the first is if somebody clearly has an alcohol problem, they're asking for help or whatever it may be, don't screen. You can immediately go on to assessing for a possible alcohol use disorder. That doesn't mean you might have all sorts of questions for them about what's been going on, but you don't need to apply a screening algorithm when the pretest probability is high. And then in terms of other reasons to potentially screen more frequently than annually, because some groups recommend annually, would be things like if somebody has high blood pressure, that could be an underlying problem with drinking too much, or if they're having difficulty sleeping or anxiety, those would be the reasons to screen. But the recommendation is routine screening, which I think we would all agree with, and that recommendation was by consensus a strong recommendation. The second recommendation is for individuals who are drinking at or below the Canada's guidance and alcohol low risk level. You don't need to spend a lot of time. You can just offer brief education aimed at reinforcing safer alcohol consumption. I think we all know that alcohol use problems tend to emerge in late adolescence or young adulthood, and there is sort of old phenotypes that we used to talk about, type A or type B alcoholism, where type A tended to be later onset. So I don't know, your kids have gone off to college and you're feeling lonely and you find yourself drinking a bottle of wine per day. That's the type of thing that primary care providers might be able to prevent in the first place when they identify people that are drinking at a low level. And so you'd have a brief conversation so they're aware, or they might have questions about a loved one or that kind of thing. So this isn't to say you wouldn't spend time, but this can be a very brief conversation if it's appropriate. And that again was a strong recommendation. The third recommendation is for individuals who are drinking above this 2 drink per week threshold to assess for possible health or other problems attributable to alcohol use that might imply an underlying more serious alcohol concern. And that's also a strong recommendation. And I'll talk about how to do that. The fourth recommendation is for individuals who exceed this level, the low risk thresholds, but do not endorse any alcohol problems. You can just provide personalized information on their circumstances and, if it's appropriate, advice on reducing alcohol use. And this is a big sort of category. You can imagine somebody who says, "Well, I probably drink 3 drinks per week." That's very different than someone who might drink 6 drinks every night. So you really need to get a sense of that. But you can just provide that advice without further screening. And again, that recommendation is strong. And then the last category or sort of group would be individuals who are above this high risk threshold who also report possible problems. And in that circumstance, again, you don't need to go into more screening. You would move directly to a diagnosis. And again, that's a strong recommendation. And we'll talk about what that might look like shortly. So you're not meant to really read this. This is available for those that really want to delve into it. But these are the 5 steps, and we'll help situate sort of sample example cases of where people might be. But the first step is opening up a conversation about alcohol use. For individuals who say, "Listen, that's not why I'm here. I don't want to talk about that." They end up on the side there where you put that off to a future time. For individuals who are happy to talk about alcohol, you can see here that you're sort of putting people into 2 categories: those who are happy to talk about it but are not drinking above the Canada's guidance in alcohol and health level. That's again a brief conversation. If they're above that level, you're assessing for possible problems. If there are no problems, then again they're going into that level where no further screening is necessary. And if they do have a problem, and that could be a number of different things, and we'll talk about what that might look like, then you would go on to pursue a diagnosis. And if the diagnosis is positive, then how to provide care for an individual with alcohol use disorder. First of all, ascertaining if it's mild, moderate, or severe, and then offering care accordingly as part of the main guideline. Next slide, please. So again, just to reinforce these steps, and then I'll pass things over to Kim, and she'll really sort of be able to outline how this works. But the first sort of sample language that we've provided, the intention is not to be really sort of prescriptive with how these conversations happen, but just to give some example text. And depending on the nature, if you work with youth, if you work with older adults, or whatever the nature of the circumstances are, people are meant to just develop their own comfort. But the idea in the sample text you can see here, I discussed the effects of alcohol with all my patients. Negative effects are now known to emerge at lower levels than previously believed. Would it be okay if we talked about alcohol today? The idea is to make it very routine. You talk about alcohol with all your patients, that it's very non-judgmental, and then, of course, respecting patient autonomy. Again, just to reinforce the point, if the patient says no, respecting their decision. It might be really important to include in the medical record if you were kind of concerned that this is something that you wanted to try and revisit in the future. So it's not slamming the door shut forever. We want to just make it as sort of non-judgmental as possible. But again, really reinforcing the point that you want to respect patient autonomy. And then in terms of the initial screen, again, we have to sort of dichotomize where people lie in terms of their alcohol consumption, in terms of how many drinks on the average week. And again, I think everyone's probably familiar with a standard drink, but a 2 standard drink threshold under Canada's guidance in alcohol and health, and whether they're above that or at that level or below. So a standard drink, of course, being like a 5% can of beer, not your sort of 7 or 8% IPA tall can. And so the sort of the thresholds are described, but 5 ounce glass of wine or 1.5 ounces of hard liquor, and then dichotomizing people above or below those thresholds. If they're below the threshold, again, this is where you're looking to just reinforce safer behavior. And this is again maybe less than a minute. Can we talk about alcohol? How much you drink? Okay, it sounds like you're not drinking very much. That's great. Don't know if you've heard, but that's really where you want to be for all of these health benefits and engaging people in a conversation as they see fit. But the idea is just to reinforce healthy behavior. Then if they're above that threshold, and this is where we can probably have some conversation at the end when we get into the Q&A, but a secondary screening, the idea is to be brief. And so again, we propose some language as follows. Do you ever have challenges controlling your alcohol use or find that you continue to use alcohol despite it causing problems in your work, relationships, or health? And that's essentially trying to get at the DSM-5 diagnosis, which I won't get too technical until the Q&A unless people would like to really delve into this. But a DSM-5 diagnosis of alcohol use disorder, of course, is a threshold criteria of clinically significant impairment or distress, and then 11 factors that can contribute to that. And for the clinical epidemiologists who really delved into this, not all 11 of those factors are created equal. So the classic example is the risky use criteria is often endorsed by individuals who have had a driving under the influence charge. And so it's been shown that alcohol use disorder diagnoses can vary internationally by how rigorously impaired driving is enforced, which of course has nothing to do with biology. So these are the kind of key elements of an alcohol use disorder diagnosis that we think are really meaningful. Next slide, please. So then, of course, there's two possible pathways. Someone might be drinking a six pack every day, like I alluded to previously. You say, do you have any problems? They say, it actually doesn't have any problems for me. And I, that's just my routine. And yeah, thanks for asking. And then you might have a conversation about, well, that's, let me tell you about the health risks of that. Or you're here with your high blood pressure, that may be a consequence of how much you're drinking. Alternatively, people might say they have some problems. That does not necessarily indicate a diagnosis or not, but let's say somebody tried to I tried to do a dry January, and I actually found that by mid-January I got invited out with some friends to have a drink, and I just couldn't resist having a drink, and I've gone back to daily drinking for the rest of January. So I kind of think maybe I do have a bit of problem. That would send you down the moving directly to a diagnosis part of the algorithm. So I'll pass things over to Kim and let Kim kind of talk about some practical ways to apply the algorithm, and then we'll get into some Q&A.
Great. Thanks, Evan. It's delighted to be with you here today. Just want to make sure people can see the chat, because for this next piece, we're going to do some interactivity so that we can kind of solve these cases together. What I'm going to do is I'm going to go through a series of scenarios that really bring to light and operationalize the algorithm that Evan has just given us an overview of today. So I'm going to talk about a scenario. We're going to hopefully put in the chat what you think the provider should do next, give you about 30 seconds or so to do that. And then we're going to go through, okay, based on the guidance, based on the evidence, based on the algorithm and the work that we have for the screening tool, what does that suggest that may be the best next step? So 20, and this gets into the routine piece too, I think you're going to see as well, as to where we want to bring up these alcohol conversations, moving away from just looking for people who may have an alcohol use disorder, and instead moving towards how does alcohol impact our life and our overall health, and not just looking at alcohol use disorders. So a 21-year-old has a toenail fungus that makes him uncomfortable wearing sandals at church picnics. So you, as the care provider, share with them when he comes into your office. I discuss the effects of alcohol with all of my patients. Negative effects are now that should be now known to emerge at lower levels than previously believed. Would it be all right to talk about Canada's guidance on alcohol and health today? So the same way we want to introduce this, that we would talk about exercise or diet or anything else. But the patient, 21-year-old male, says, I don't drink very often and I prefer to focus on my toes today. So putting in the chat, what do you think that you would want to do next? And before we go to the next slide, maybe take a second to think about what's your next step as the care provider. What do you do? What do you say to the patient? I'll give people a sec. Good. Okay, so I'm going to read some of them because I know some people may have a hard time following along with the chat. A lot of focus on what we heard from Evana in the beginning about respecting autonomy, focus on what the presenting problems, moving on to the next step, and all, but yet leaving the door open. I see that in here as too. So if we move to the next slide, you can see you guys got this bang on. So we're not going to address this currently to the patient because it's not today. We're going to respect their autonomy and move forward with what they want to talk about. But we want to indicate that openness to talk about the health effects of alcohol at any time they want. So we're going to say, that's good, not today, but let me know if you want to discuss in the future. I'm here, I'm open. And I may even ask you about this again in the future because I ask all the patients about this. We may even want to chart that information and then move on to the next step. So again, we go back to those core principles about this routine administration, no pressure, as I just saw William put in the chat here right now, and respecting the autonomy and moving along. So good. I'm glad you're playing along with me. It was going to be really boring if I was doing this by myself. So thank you. I will encourage this and reinforce this for the next one. So let's go to the next case. So 50, thank you, William. A 55-year-old retiree presents with low mood and feelings of loneliness in the wake of their youngest daughter going off to university. And we heard from Evan, that is often a common experience that I see in the practice that I have as well, when, change of lifestyle or change of life circumstance may often lead to change in our lifestyle behaviors, which could include drinking. So they are agreeable to talk about alcohol, but after hearing about Canada's guidance on alcohol and health, because you're going to tell them about it, they said they don't drink regularly and that maybe they're drinking every month or two. And even when they do, it's a maximum of 1 to 2 drinks when they're out for dinner. Okay, so based on what we heard about the guidance, we went through that algorithm. Do we need, as the care provider, to do further screening? What do we do next? Okay, we got people saying, do you ever drink more? So some people saying yes. Extra questions. Some people are saying, no, let's reinforce that low risk drinking. We could say, hey, maybe we have some concerns if the person is willing to drink more. These are just the things that are in the chat. Okay, we've got some people wanting to prompt a little bit more about their loneliness and sadness, which, that may be a way to go next too. Okay, so if we go to the next slide, and remember, this is just about drinking, not the fact that there may be other things we want to ask some further questions to our patient about, if they're feeling lonely, they're feeling sad, etc. Or maybe we're concerned that they could be drinking a bit, or that their drinking could, they could end up with increased drinking behavior. But at the current time, further screening wouldn't be really considered necessary because they're below that SIGA threshold. But what we do want to do is what you've pointed out multiple times in the chat. We want to give them some brief education aimed at reinforcing safer alcohol use. And that could be provide some pamphlets, some toolkits, having a conversation, and also letting them know, hey, maybe they'll start paying attention to their drinking. Now that they know what the SIGA guidance is, they'll start maybe thinking about that a bit more and leave that door open so that they can come back. So at that point, no other screening, brief education, but we always want to make sure that patient knows to come back and reinforce their safer alcohol use. So next, now we're going to talk about someone who presents above the threshold here. So this is a 30-year-old carpenter who comes to you because they need a note for their workplace after sustaining an injury while they were playing softball. So not a workplace injury, they sprained their ankle. They express a willingness to talk about alcohol and describe limiting drinking to a can of beer after work and a max of 3 drinks when they're socializing 2 to 3 times per month. They acknowledge drinking 2 to 3 beers before the injury occurred during their baseball game. So we as the care provider say, the question that we want to do now is, do you have any concerns? Remember, we're now at that part 3. Do you have any concerns with your alcohol use, including controlling your use, or that you continue to use alcohol despite it causing significant problems in your work or social relationships or problems with your physical or mental health? So the patient strongly denies problems of this nature, volunteers 0 problems taking the month off of drinking in January with their partner when they both felt they were drinking too much over the holidays. They say they do not have health or social problems or any issues attributed to alcohol. So do we need to screen further? for alcohol use disorder. Remember, now they're endorsing being above the threshold. We just asked that question, which is in step 3, but are we going to move forward with an alcohol use disorder screening at this time? So some further diagnostic interview. And we have some people saying no. Some people are saying yes. We do want to move forward. Some people are saying no. We're on the fence with this one because maybe from the case we're thinking, well, maybe they are having more problems, but they just denied having problems. And they're basically saying, no, I'm not really having any concerns. So also have to think about if we continue to probe, where does that go? So maybe this is an opportunity for conversation. And when we go to the next slide, we can see, well, at this point, a couple things. It's probably not suggestive of an alcohol use disorder, but I think what we're all pointing out, and you're seeing this in the chat, they are at risk of health consequences. They just talked about having potentially an injury, but they're also saying they don't have problem stopping and that they're not having other issues on their functioning. So at this point, we want to provide some advice on the progressive increasing risks and strategies, progressively increasing risks they may experience, as well as strategies to reduce alcohol use. So we want to have some focus on the health effects of those 7 to 10 drinks per week, according to the Canada's Guidance on Alcohol and Health. And we also want to have people, have this patient have greater awareness of their risks related to their injury, and how that impacts their health and wellness. We want to have some of that personalized information related to their risks and focus on what people can do to stay well and healthy and reduce harm. We also want to recognize that, okay, when this patient comes back, this may be an opportunity for asking these questions again. And that's why when Evan talked about at the beginning, what do we mean by routine? Well, all these are opportunities for a conversation, and all these are opportunities for us to have a screening. So maybe, now's not the time, but when they come back in for their checkup, we can ask them how they're doing again. It gives us an opportunity for that, even checking in on how they're going, if they've considered about reducing their alcohol use just for their overall wellness on their health. We go to the next slide. Next one is on a binge drinking case. So this is and I see lots of info in the chat, and I cannot follow along with all of you while I'm speaking, but I am picking up on some of this, and I saw some discussion in the chat around our young people. So a 22-year-old university student presents to your clinic to discuss her oral contraceptive. She's agreeable to start to talk about alcohol and indicates she only drinks about twice per month and says she doesn't feel she has problems with her alcohol use. But when we quantify her alcohol use with the algorithm that we just discussed, all those steps, she does discuss heavy drinking nights, often after her exams, and that her friends have put themselves into risky situations during these episodes. In fact, she recalls that one of these nights, a past boyfriend of hers got into a physical altercation outside a bar, which was really out of character for him. The student's drinking pattern is consistent with the SIG-identified progressively increasing risks that emerge during drinking episodes above 2 standard drinks. So based on that, is this suggestive of an alcohol use disorder? What do folks think? Possible AUD or not? Some people think it's an alcohol use disorder. Some think it's potential. Some say potential. And it's really interesting because then you get into this concept of binge drinking. And when people aren't having those regular drinks, but yet it's episodic, they could still be at risk. But maybe this is time for having that conversation, and I'm seeing all those other pieces around here. So if we go to the next slide, so if we look at those algorithms on itself, it's actually not suggestive of an alcohol use disorder, because these are episodic binge drinking. But what we do want to do is address what you are all talking about in the chat, is the risks that can come with heavy episodic or binge drinking, including an increased risk of harms to self, to others, violence, injuries, other risks to our health, etc. So high risk, not suggestive at the point for alcohol use disorder, but again, at risk of health consequences. And that's what's really interesting when we apply this screening algorithm to our patients. we're going to identify a lot more individuals than we ever used to with the previous screening tools, because we're going to identify individuals with risks of drinking, of people's drinking on their health, not just amongst an alcohol use disorder. So our opportunities for intervention and education and connection with our patients around this topic are really going to increase. So again, with this patient, this young girl, we want to provide personalized information on alcohol use and her risks, and then, of course, advising on some of these strategies to reduce risks and harms. Hey, next slide. All right, we have 2 more. Stick with me. Okay, so this is what do we think about AUD for this one? And you're going to see how that contrasts with the last case. So this is a 30-year-old teacher presenting to us with a concern about his insomnia, and he's feeling really anxious. And he agrees to talking more about alcohol. And when you go through the algorithm, he describes drinking up to about half of bottle of wine daily, and sometimes more. The care provider says, do you feel you have any concerns with your alcohol use? We asked the typical question that we did. I'm not going to read it again. I've now read it 3 times. And to that screening question, which is the one that we're really probing there around alcohol use disorder diagnosis possibility, the patient describes a single impaired driving incident a few months ago, and some recognition that alcohol, while temporarily can help him fall asleep, probably is worsening his sleep overall. So at this point, do we assess for a possible AUD diagnosis? And I got lots of people in the chat saying yes. Oh, we've got exclamation points. Lots of enthusiastic yeses on this one. And if we go to the next slide, yes, absolutely. We do want to, there is a possible problematic alcohol use concerns here. And we do want to undertake that DSM-5 diagnosis for AUD. And so the next thing we want to do is move forward to assess for that and offer care accordingly. But we're going to break this down into 2 scenarios so we can see what happens, so we can get to the care planning piece too. So if we go to the next slide, possible A is, let's say we don't reach an AUD diagnosis. Just go with me here, even though you're really convinced they have an AUD diagnosis. We need to show both sides of the coin here for illustration. So if no AUD diagnosis is reached, we still really need to look at how we're providing that education on risks and where appropriate strategies to reduce alcohol use. And here, those brief intervention-based strategies for reducing alcohol can also be provided to stress the risk associated, especially because this client brought that up about driving while impaired, along with, we also want to provide some closer regular follow-up to assess progress. This is someone we want to keep a lot of an eye on here, and we don't want to just, send them off and saying, well, you're good to go. We want to make sure that person continues to come back, because let's say they do try to cut down on their drinking, but they're really not successful despite that attempt. This person could ultimately end up being diagnosed with an alcohol use disorder. Other patients may not be if they could cut down, but maybe he cannot, and that leads him to ultimately a diagnosis. But for now, not. Scenario B. Let's say an AUD diagnosis is reached. At this point, we want a discussion about the initiation of treatment. If you're not familiar of the full CRISM guideline, check it out. It's been in the chat. It's linked on these slides as well. And here you can initiate the appropriate intervention depending on the severity of the alcohol use disorder that this patient is determined to have, either mild, moderate, or severe. And that would be our next step there. Last case, and sadly, there's not a Q&A part in here for you to add to, but please put your thoughts anyway, because I'm really appreciating the interaction here. So let's say this is a 35-year-old lawyer. Sorry, I'm distracted by the chat. I will stop reading. Who presents to us having been admitted to the hospital for an alcohol attributable pancreatitis the previous week. We see in their records that this demonstrates that the patient demonstrates a history of asking for help to cut down on their alcohol use approximately 2 months prior. So at this point, we don't need to do probably any further screening. We need to move directly to an AUD diagnosis. It's fairly unambiguous, and we go back to what we talked about in Evan's part at the beginning. We have a very high pre-test probability of alcohol use disorder here, just based on what the client has been admitted to for hospital, as well as their records, as well as the patient's self-report. So we want to skip that screening and move directly to assessing for alcohol use disorder according to the DSM-5 criteria. If we go to the last case, this is on a young person. We want to make sure we had this is the first young person binge drinking episode. That was person who was 22. This is a really young person who's 15. And they seek, they're going to see us because they're looking for antibiotics after a minor cut has become infected. We want to use a really calm, open, collaborative, curious approach to opening up a conversation with our young patient about alcohol. And we said, Canada's current guidance highlights that youth alcohol use can be extremely risky for serious harms and recommends youth delay as long as possible. Of course, I'm aware it is not uncommon for young people to start experimenting with alcohol at your age. Have you noticed that some of your friends have begun trying alcohol? So really want to normalize this, want to open it up about speaking about their peers, and give them an opportunity to engage in a conversation. And the young person actually shares that some of their friends have stolen their parents' alcohol, and that one friend has an older brother who's brought them beer. He then describes his own use as limited to once or twice in the last 6 months and that he hasn't had any problems. What do we do next? I'm seeing prevention, education, not an AUD. Any other thoughts with this young boy? Yeah. Lots on reinforcing behavior. And if we go to the next piece, again, we want to really use this opportunity to provide education on both the short and long-term risks of drinking underage, which includes injuries, violence, worsening academic performance, and really try to make it clear that there is no safe level of alcohol use for young people that has been identified, and that our recommendation is about delaying alcohol use as long as possible in our young people. We also want to indicate that we welcome a follow-up appointment at any time in the future should future concerns with alcohol emerge. And I love what people are putting in here. Really thank the young person who's talking to you for their honesty. And I also think it says something about your therapeutic relationship with this patient that they've been able to open this up with you. So I think that's good on you too. So let's wrap this up. This just summarizes what we've talked about. Again, even without an AUD diagnosis, which are probably going to be the vast majority of patients that you see in your practices if you're in primary care, even without that, we want a care approach that focuses on the potential health risks of alcohol, normalizes the ability to reflect on our alcohol use without labeling, and giving that brief evidence-informed intervention. We want to focus awareness on the Canada's guidance on alcohol and health, the risk thresholds. We want to identify patterns. We want to connect alcohol use to other issues that the person may be coming in with, if they're concerned about their mood, their injury, their sleep. And many of y'all pointed that out in the chat. And then as we talked about, the next steps on simple reduction strategies, small realistic goals, if that is what the patient is interested in, and always keeping that door open and arranging follow-up if needed. Next slide. If there is a diagnosis that's made, we want to confirm that diagnosis using the DSM criteria and assess that severity. We want to use the CRISM guidelines that are in the chat there for you to discuss the treatment options with the patient, which include behavioral and psychological, pharmacotherapy if appropriate, and then referral to specialized care if need be. Always wanting to ensure that ongoing support for the patient. It's okay, keep going. And then these are just some examples that you can find for practical strategies for lower risk or reducing alcohol use, or even keeping and reinforcing the healthy use of, or safer use, I should say, of alcohol. And if we move to the last slide, just some final thoughts to wrap this up. I think it's pretty clear that harms related to alcohol, as we saw right from the get-go from Evan, are common and they're under address. The traditional screening approaches that we're used to, that Evan talked about, those 4-item or 10-item tools, have limited real world use. And we know that because people aren't using them. So what we came to bring forward today in these new set of recommendations are really aimed to reduce those barriers to screening, open up who we're having conversations about alcohol with, supporting the conversations and the dialogue around healthy and safe use of alcohol or addressing risk, identifying risk early, and then intervening as appropriate. So having those better conversations allows us for earlier intervention and appropriate intervention when we need it, as well as improving the outcomes for our patients and their communities. And I'm going to turn that back to you, Evan.
Evan, you're muted.
Thank you. Sorry. Just loving seeing all this interaction in the chat and someone asking about getting a copy of the presentation, which absolutely we can circulate. Bryce, over to you. And I think you've been helping collate some questions for us and welcoming questions as they come in the chat as well.
Thanks, Evan. I'm Bryce Barker. I'm a senior knowledge broker at the Canadian Centre on Substance Use and Addiction. Happy to help out with questions today. So we did have questions coming in with registration forms, and we have some open questions. So we'll try to get to all of them. We do have some time. We'll see how we do. So the first question is going to be for Evan, and they'd like to discuss the basis for question in step 3 of the algorithm and the recommended adaptations if providers don't have time to do a full DSM-5 diagnostic.
Yeah. Okay, that's sort of 2 questions. The first for people that are interested, and I always find just how specialized people can be in research. And there are people who have made a career out of for lack of a better description, kind of picking apart the DSM-5 diagnosis of alcohol use disorder. And people may not know that even in the best of circumstances that were created to do the field trials with the DSM-5 alcohol use disorder, the kappa or the retest statistic where 2 independent people would go and see a patient and try and ascertain whether they had an alcohol use disorder or not, the kappa was only 0.4, which means about a third of the time, the 2 expert clinicians would look at each other and say, well, I think, and disagree. And so there's first that as the underlying diagnosis. And then when people have really gone into detail and looked at those 11 criteria, as I alluded to, they're not all created equal. And then a little bit more nuance is that people may remember we used to have alcohol abuse and dependence. And now we have this notion of a mental disorder, but where the threshold for a mild alcohol use disorder is very, very low. I sometimes with the fellows in our addiction medicine training program use the example that I'm a sweet tooth. And so if I see like cake in my fridge, I will crave. And I will sometimes go back to the fridge and have more than intended. Well, those are 2 of the criteria. So I don't think I have a cake use disorder, but I use that as an example as that threshold criteria of clinically significant impairment or distress. And then those 11 criteria. So what we did to answer the first part of that question is we really tried to distill down in a brief way. Do you have problems controlling your use, or do you continue to use in the face of health or social harms? And that really is the most sort of important pieces of the alcohol use disorder diagnosis. But again, apply that, as it makes sense to do so. And as you see fit. If it's a youth, it's very different. The NIAAA, one of the National Institutes of Health guides, as Kim has alluded to, suggests asking young people about their peers' alcohol use first as a way to sort of diffuse that being a potential question where the young person might be reluctant to volunteer. To the second part of the question, an alcohol use disorder diagnosis, once you get used to that, it doesn't need to take that long. You really can once you're comfortable with that, and I don't want to get too out of scope, it doesn't need to be too time consuming. And the idea here is, to be triaging most individuals as not needing to get into the diagnosis. It would only be in individuals that describe they're having problems. You could still, on the nature of someone's problem, maybe not entertain a diagnosis if you felt it wasn't necessary. But I think to the second part of the question, that just doing a quick alcohol use disorder diagnosis may come from multiple follow-ups, so it's not always quick, but going through those criteria and explaining to patients shouldn't take too long.
Oh, that's great. Evan, I might direct you to the chat. Sean Martin just asked a question that was related, but I would just the second part of the question, maybe just while you're on this, are there any alternatives you recommend that would allow a provider to make an informed decision on pharmacotherapies like naltrexone or camprosate, both of which are so underutilized?
Yeah, just very quickly, generally for somebody who's trying to cut down on their alcohol use, naltrexone would be the one I would reach for if there were no comorbidities like insomnia, because naltrexone tends to interfere with sleep, and I see it often prescribed to people who are having sleep problems, and I think that's counterproductive. Acamprosate has the drawback of being 3 times a day instead of once per day, but tends to be the evidence best for people who are really motivated for abstinence. So if someone really wants to quit drinking, then think acamprosate first. If someone wants to cut down on their drinking, naltrexone, though the side effect profile is a little less desirable, is it tends to be really effective for helping people reduce their alcohol use. There's lots more about that in the main alcohol use disorder guideline.
Excellent. Thanks, Evan. So the next question will be for Kim. Any strategies on how to create incentives for physicians in primary healthcare clinics to implement routine screening, available e-learnings, electronic medical record integration?
Yeah, absolutely. So first off, hopefully an easier screening tool that isn't cumbersome, as we've discussed today, and that you can easily put into your conversations with patients will be helpful because we know the lower the barrier, the screening mechanism, the more likely people are to screen. A few other things we talked about. I heard in the question something around EHR integration. Of course, that's helpful. But I think also reframing screening as part of a lifestyle conversation. We often talk to our patients around diet and exercise and sleep, adding alcohol to that list the same way we do. And I think as we reframe it that, it really moves us away. Just alcohol use, I mean, obviously I work with people with severe substance use problems. Alcohol use disorder is an important diagnosis to make if we need to make it. But we also have many patients who are coming to see us for many other presenting health concerns where alcohol could be impacting their health, but we'd be missing those individuals in the discussions that we've having so much lost opportunities to impact the health of our patients and to support them with their healthy lives. So I think, supporting that, increased comfort with prescribing AUD medication. So I think as people become more comfortable with prescribing, they're going to be more likely to screen. People are going to screen if they're not sure what to do with it. Make it really clear. So if in the EHR, it can be really clear as to even having this algorithm as part of people's EHR, of providers' EHR, that could help them. And of course, fee codes. Can never have a conversation about incentives without fee codes. But I didn't want to only lead with fee codes because for screening, and there are some, in terms of making people aware of what those codes are, or having specific codes that promote the screening around that. Just in interest of time, I'll wrap it up there, Bryce.
Yep. Thanks, Kim. So next question over to you, Evan. So use of breathalyzer as an education tool to alert to danger driving in office and in patient's home. Are there ones available to purchase reliable? Question just about breathalyzers here.
Yeah. Yeah, that's probably more of a specialty sort of question, but happy to answer it. In terms of the accuracy, the units that I think are commonly used, and presumably that's because they've been well validated, are the SoberLink devices that is probably sort of captured most of the market. And I'm not familiar, but I know that there's lots you can probably buy on Amazon and things like that, and I couldn't really speak to. I think they get used in specialty environments a fair amount when people are being admitted to a detox, for instance, or other circumstances. But in primary care, that's probably only after serious, alcohol problems have emerged, and after an alcohol diagnosis, alcohol use disorder diagnosis has been made. So probably less relevant for screening.
Okay, excellent. So next question for you, Kim. Are there any special considerations for older adults?
Yeah, and I wonder, Bryce, if I can, there's questions about older adults, there's questions about youth. So I may put them, although they're not the same, obviously, I think a lot of the questions are in special populations. And Nancy reminds me And I do not know why I missed this. So my apologies, Nancy, that we didn't specifically talk about alcohol and gender and health. And as appropriate in the chat that Nancy points out, is the importance of having this conversation about the health risks and how that's different for women and men, and then how social harm risks for men, and that having this as a routine part of discussing the guidance. And Bryce, maybe we can put some of any of that into the chat so people can look at those discussions as well. So thank you, Nancy, for that. In terms of older adults, so as people, older is now defined, and I also know we have Marilyn here who's an expert in this as well, because I saw her in the chat. So Marilyn, please feel free to put anything as well. As people approach 65 and older, our bodies change, our lifestyles change, the way we react with alcohol changes, and alcohol actually can become riskier. So we process alcohol more slowly. We could actually have a higher blood alcohol concentration per drink. The impact alcohol was going to have on our strength, our balance, our coordination can all actually increase falls. People are more likely to have polypharmacy, so be on many medications, and that can interact with alcohol. And although alcohol can impact our brains at any point of our age, there is the impact, of course, that's disproportionate to the impact of memory and cognitive functioning on our older adults. And then alcohol being used as a way to manage loss, grief, retirement, changes as we get older. So Bryce is going to put in, if he hasn't already, the Canadian Coalition for Seniors Mental Health encourages adults to consider cutting back or cutting out alcohol completely. And we're going to put some of that guidelines in the chat right now for you to look at. I know youth was another one that keeps coming up in here. Both Evan and I talked about the message for Canada's guidance in health is to delay use as long as possible. So if a young person hasn't started drinking yet, that's important and helpful to iterate. In general, we really want to focus on the same message of less is better. If young people have started drinking, we want to focus on drinks per occasion. When that makes sense, because they tend to drink higher amounts on occasions when they do drink. And again, we talked about both the guidelines as well as from our other guidance we have on talking to young people about alcohol, is we really wanted to ask them about peer alcohol use, starting with that rather than their own, because it opens up that door for conversation. And we're putting in some resources in the chat as well. Oh, sorry, fast as I could go.
Doing great. So next, there's two questions. I'll give you the first part, Evan. So I would love to hear some commentary on use of this screening guideline in an occupational medicine setting and determining fitness for safety-sensitive work. So there's a follow-up that I'll get you with as well.
Yeah, great question, and it's very relevant. I think it's very scary. I know, just as a physician, when you meet someone and say, "Oh, well, I'm a taxi driver," for instance, or I work at in a heavy industry or whatever it may be, that suddenly flag, okay, this individual could be putting them, their coworkers or the public at risk. So it's very important. This is really meant to be a primary care-based screening. And usually when someone is seeing a physician in the occupational addiction medicine context, the pretest probability would be so high that you may move directly to a diagnosis. Then, of course, that triggers making the point that the DSM-5 diagnosis is based on self-report. And so it would really depend on the circumstances. So a safety-sensitive worker could be a physician who had a driving under the influence charge while away on vacation. And, you'd really need more information to know, is this just a really bad decision? Or does this person have an alcohol problem that could impact on public safety in terms of impairment in the workplace? And that gets really complex. And I probably, we probably could have a dedicated webinar on that. In this context, I think just acknowledging that the screening is really intended for primary care, where people might not have a secondary interest, like I don't want my health professional, college, or employer to know, and therefore I'm going to underreport my alcohol problem. And so you'd need to be aware of that. This is really intended for just primary care, where people are hopefully, by a non-judgmental approach, going to be willing to, fully disclose what's been going on in their life. The occupational context could make things certainly more complex. So if that question is being asked with that intention, I definitely agree.
And Evan, before I get to that second part, I'll just point your attention to Nancy's comment, just thanking Kim for talking about sex and gender. And she wanted to add just about diagnosis for women with children. A fear of loss of custody needs to be discussed. This is a major barrier to disclosure and help seeking for women with AUD. And I bring it up just in relation to work, maybe some similar considerations. And it does lead into the second part of this question. So how do you approach a patient regarding ministry reporting for alcohol use disorder? And again, I wasn't sure which ministry personally that was referring to, but maybe that jumps out at you, Evan.
Yeah, that would probably depend on the jurisdiction, but an ascertainment of, if young people are involved and you do have very serious concerns about the well-being of a child, then that triggers, legal obligations depending on the jurisdiction. In British Columbia, the Health Professions Act might be involved. In other circumstances, it'd be like, this person has a partner, they're managing, they're whatever it may be. You would have to use your judgment there. So another sort of complex question that's really, really important. But maybe a little bit out of scope of primary care screening. But these are the more we screen, the more of these types of things are going to be seen. And yeah, for a physician, phoning a friend and your regulator and, those types of things that availing yourselves of the resources around you that you would normally in those complex cases, and, putting the patient and the interests of young people, centrally in those conversations.
That's excellent. I would just point out that we have 11 open questions. I don't think we'll get to everything. So my apologies in advance, but we will try to work through them. Maybe we can do it, again, without clipping your answer too much, if we can get through a few of these questions in the next few minutes. And I'll leave it between you and Kim, Evan, to just jump in with the answers. So what theories and practices can assist a non-healthcare provider when someone is struggling and wanting to listen and learn more about attempting sobriety? Thank you for letting me share. This is from Leo Petrilli.
Kim, do you want to take that one?
Sure. Oh, in 10 seconds, that's a lot. So I think, well, frankly, Leo, you got a bit of your answer. And first of it's all, we want to understand people's readiness and meet them where they're at. So that's why, asking the questions disappeared, but asking people, their permission to have a conversation about that, always keeping that door open. And as I said, matching the interventions that we have with people's readiness for change. We do not need to do a whole, in detail readiness for change assessment, but at least getting people's a sense of where they are on kind of a red, yellow, and green light. Are we ready for this conversation, or are we? Is this not where we want to go right now? And then matching their interventions to that. I'm not going to be able to get more than that, Bryce, but I'm sure we can send along. We have some resources that can help.
Yep. And maybe, Evan, I'll leave this. We'll give Aaron Hoban the last question. So thank you for the presentation. And is it possible for non-physician staff to conduct alcohol screening and brief education interventions? And so this will be the last question we get to, and then we'll finish up. And apologies in advance for not getting to everybody.
Yeah, absolutely. Absolutely. This is intended for, interdisciplinary audience, 100%. So, counselors, social workers, nurses. This is not a physician-centric approach. This is really intended to be the opposite of that. This is for initially educating people about Canada's guidance on alcohol and health, and then recognizing, as Kim has done so nicely, an elder versus a child versus someone who's drinking 3 drinks a week or someone who's drinking a 26er a week. It's very different, and tailoring the interventions accordingly, and obviously, prospectively following people and getting more information and supporting them in their journey. That's the goal, and it doesn't necessarily, by any stretch of the imagination, have to be physician-led.
Excellent. Well, I mean, I can pass it back to you, Sabina, if you'd like the last word, but that'll be all the questions we get to today, and really appreciate you taking the time to ask the questions, and hopefully, if we didn't get to your question, you got some answers from what we discussed so far.
Yeah, thank you so much, Bryce. Thank you so much, Evan and Kim. As you can also see on the screen, once again, we're so sorry that we couldn't get to all the questions, but any additional ones you have, you can send an email to my email right there, and I can send it off to Evan and Kim, and they will be able to give you those answers as needed. It is also the email that would have been associated with this webinar, so you already have that contact as well. And again, we will be sending out a recording as well as a link to the guidelines, a link to the presentation. So you guys will have all this coming up. We really encourage you to share it. And thank you so much for attending. You guys have been a great audience.
Thanks so much, everybody.
Thank you.